Pediatric cataract associated with any anomaly can challenge the best of surgeons, particularly when associated with congenital rubella syndrome, posterior lenticonus, persistent hyperplastic primary vitreous, ectopia lentis, cataract and Stickler syndrome, or uveal coloboma. Congenital rubella is one of the most common causes of childhood cataract in developing countries. The common manifestations of congenital rubella syndrome are congenital cataract, congenital heart disease, commonly patent ductus arteriosus, sensory neural deafness, and rubella retinopathy. A systematic approach for the management of congenital rubella cataract will be illustrated here. The pre-operative evaluation, modification of standard technique of pediatric cataract surgery in difficult situations such as total milky white cataract, absorbed cataract, fibrosed and calcified anterior capsule, non-dilating small pupil, and microcornea. As well as the steps of post-operative care will be demonstrated now. Perform the systematic workup for unilateral and bilateral rubella cataract, starting with proper history taking, visual assessment, and examination with handheld slit lamp. Examination under high magnification can be done with a 20 diopter lens in the absence of a portable handheld slit lamp. Meticulously evaluate the anterior and posterior segments, particularly looking for posterior synechiae, intraocular pressure, and salt and pepper retinopathy if possible. P-scan examination in case of total cataract, torch titers for rubella IgG and IgM antibodies of the baby and mother, first year of life, 2D echo, and Doppler test to rule out congenital heart disease, and brainstem evoked response audiometry for congenital sensory neural deafness. Measure the horizontal corneal diameter, the axial length, and the intraocular lens power. As a safety measure, include a pediatric anesthetist in the surgical team. In preparation for the surgery, position the child with the head slightly higher to reduce positive pressure. Reduce the intraocular pressure by hyperventilation, and use a pediatric speculum to avoid pressure on the globe. Surgical consideration will be demonstrated now. In total milky white cataract, stain the anterior capsule properly with trypan blue and gently initiate a continuous curvilinear capsulorhexis with a cystotome. Complete the capsulorhexis with a pediatric capsulorhexis forceps. Avoid vigorous pressure during rhexis and direct the force towards the center of nucleus, and defer any hydro procedure as it can cause posterior capsular rupture if there is an underlying posterior capsular plaque. Remember that the complete removal of all cortical matter to avoid the intense post-operative inflammation is mandatory. In the eventuality of an absorbed cataract, perform all maneuvers very gently. The slightest stretch on the zonules during capsulorhexis can lead to zonular dialysis. If there is a zonular dialysis, use an automated vitrector to complete the capsulorhexis, or using a cystotome, make a small opening in the anterior capsule. Aspirate the lens matter in the bag using bimanual irrigation and aspiration. Very carefully remove the cortical matter from the fused peripheral bag. For a fibrosed and calcified anterior capsule, perform an initial gentle capsulorhexis. Carefully aspirate the lens and follow it up by completing the rest of the anterior capsulorhexis with a pediatric capsulorhexis forceps, taking utmost care not to apply any undue pressure on the zonules. Use a pair of micro scissors to cut the fibrosed capsule without stretching the zonules. For central anterior capsular plaque, first ensure adequate viscoelastic insertion and then perform a gentle capsulorhexis along the edge of the calcified plaque. The presence of iris hypoplasia in children less than 6 months of age is indicative of a non-dilating pupil, which is a typical presenting feature of rubella cataracts. Usually, the pupil cannot be dilated adequately by stretching the pupillary sphincter. Pupilloplasty using automated vitrector may serve to enlarge the pupil size. Remember that adequate dilatation with minimal surgical trauma can be achieved by using iris hooks. Microcornea in rubella cataract provides a narrow field of visualization along with a high risk of endothelial decompensation. Aspirate the lens matter in the bag using bimanual irrigation and aspiration. Then, make both the anterior and posterior capsular openings using an automated vitrector. On the day after surgery, perform visual assessment for fixation behavior, fundal glow on direct ophthalmoscope, and visual acuity on telar acuity card in older infants. Also, perform an anterior segment examination with handheld slit lamp. 1 week after surgery, perform an evaluation under anesthesia. Perform refraction and then fit the contact lens or glasses as appropriate. Educate the parents to look for the warning signs of infection as well as inflammation. Teach parents how to instill eye medications. Tell parents about the importance of the child undergoing examination under anesthesia once every 3 to 4 months in the first year. Suggest to the parents that a periodic change of eyeglasses along with appropriate eye patching can lead to optimal visual outcomes. Usually, every child with congenital rubella syndrome makes a unique presentation. Each of these presentations demands proper preoperative evaluation, intraoperative case-specific modification, and utmost care post-operatively. It is a surgeon's responsibility to ensure the child's regular follow-up, appropriate optical rehabilitation, and amblyopia therapy. All these steps are mandatory when one is aiming to achieve optimal visual outcomes for treating childhood cataract in congenital rubella syndrome.